So this afternoon, I'd like to welcome everybody to the talk with Andrea Croft, Thromboprophylaxis Risk Assessment for Patients with Lower Limb Immobilization. Gosh, I'll get that out in a minute. I'm really delighted to welcome Andrea here. She is the lead advanced nurse practitioner. After inheriting the management of a hospital INR clinic in Bridgend General Hospital back in 1995, she thankfully developed an interest in anticoagulation. And this passion and her enthusiasm for anticoagulation has continued. And she's one of the original members of the All Wales Hospital Acquired Thrombosis, or HAT steering group. Under Andrea's guidance in 2015, the Princess of Wales, Maestig General and Meath Port Talbot hospitals in Andrea's health board were all recognised as thrombosis exemplar centres. While in 2018, the Abertour Morgwanwg University Health Board, a nurse-led thromboprophylaxis reassessment tool, headed by Andrea, was overall winner in the Anticoagulation Achievement Awards category for the best work in prevention of hospital-acquired thrombosis. So her passion around anticoagulation and clot prevention has really continued throughout those years. In 2019, she then wrote and helped produce a patient information booklet, which was awarded the best resource for sharing information about anticoagulation therapy in the Anticoagulation Awards. And in fact, this booklet has now been distributed over 100,000 copies. So it really has been a popular booklet in hospitals and is available on the Thrombosis UK website. Today, Andrea's going to share locally initiated work to successfully develop a lower limb immobility risk assessment tool. It's enough of me, and my pleasure to hand over to Andrea.
Oh, thank you, Jo. That was very nice things you said there. Well, I should have retired last month, but I just love my work so much, I decided that I would stay here and do a bit more. So welcome, everybody. And this afternoon, as Jo said, I'm going to share with you the thromboprophylaxis risk assessment for patients with lower limb immobilization. So if anybody's got any questions, please put them forward to Jo, or anything burning, just stop me and we can chat about it. And well, we'll see how we go. And now this won't move. Jo, help. Sorry about this.
So rather than press, click the buttons, the arrow buttons.
I am clicking them, it's not moving. Oh, crikey, hold on a second. Let me do it to the bottom there. Yeah, I'll do that one, that's okay. Right, so first of all, I'd like to thank my co-author, Rhian Donald, who's the senior pharmacist in the Princess of Wales Hospital in Bridgend, with an interest in anticoagulation. She and I developed this, this tool back before COVID, and unfortunately COVID got in the way and held us up a little bit, but with the help of other colleagues, we were able to finally get things moving. She's not able to be with me today, but I just wanted to recognise her as the co-author, so thank you for that. Whoops, I've got nothing to disclose. Sorry, my buttons are all going all over the place. Okay, so there is a need to risk assess patients in the trauma clinic and in the A&E department within with lower limb immobilization due to the risks that the patient faces in developing a venous thromboembolism during their recovery period. And we've known this for quite some time. It was only in CG 89 in 2018 when it came out, the NICE guidance, that there was actually a reference to lower limb immobilization. And in that document, it states that patients over 16 years of age with immobilization of a lower limb in a way that would prevent normal weight bearing or the normal use of that limb, including rigid immobilization. So that could be with a cast, or it could be with a frame on the limb, non-weight bearing status, or an acute severe injury such as dislocation, fracture, or a complete tendon rupture. And for these group of patients, we should consider thromboprophylaxis. So, as I said, the CG 89, which was the NICE guidance that came out in 2018, states that we should consider pharmacological VTE prophylaxis with low molecular weight heparin or fondaparinose sodium for people with lower limb immobilization whose risk of VTE outweighs their risk of bleeding. We should consider stopping prophylaxis if limb immobilization continues beyond 42 days. And in the tool that we've written, the 42 days is the length of time which we've recommended that the treatment goes on for. And then at the end of that 42 days, or when the patient becomes mobile again, we would then review and decide whether to stop the treatment completely or whether we needed to carry on if the limb remained immobile. And there's a growing body of evidence of hospitals nationally substituting the pharmacological VTE prophylaxis, which generally is currently low molecular weight heparin, with a direct oral anticoagulant or DOAC. And in the case of our tool, we're going to be using forrivaroxaban 10 milligrams as first line choice and enoxaparin as our second line low molecular weight heparin. So evidence supports the use of oral factor Xa inhibitor prophylaxis in other settings, such as post-operative thromboprophylaxis in orthopedic patients, and the 10 milligram dose in extended prophylaxis in knee replacement patients for 14 days. The Royal College of Emergency Medicine did a national quality improvement project regarding VTE risk in lower limb immobilization, and their report came out in 2019. And that report included a small use of DOACs within the study. The study was carried out in all of the 4 nations of the United Kingdom. And it's a really good paper. I don't know if anybody's familiar with it. This is it here, if you hold it up. It's an excellent study. It's very well written. It's very informative. And we found it a very good basis to start our plans for implementing our tool and where we were going to go with it in the future. The project made key recommendation of 3 standards be put in place for this particular patient group, and we adopted those standards, which I'll go through in a moment. So health boards and trusts in England and Wales are utilising thromboprophylaxis risk assessment tools for patients with lower limb immobility in their outpatients or A&E departments, offering patients a DOAC. As far, well, we know in Cardiff, Sheffield, Leeds, and there was one other place, but I can't remember, Alderhay, I think it was. So there are a few places that have already started using the DOACs. The thromboprophylaxis continued for the duration of immobilization, and we've gone with a NICE guidance of 42 days. We looked at Cochrane, NICE, and the Royal College of Emergency Medicine guidelines. So there is some data out there to support our decisions. And evidence supports the use of the oral factor Xa inhibitor prophylaxis in other settings, as I said earlier, in post-operative thromboprophylaxis in orthopedic patients. And of course, we've also got this National Quality Improvement Project, which is just packed with a lot of really useful information. So the Royal College of Emergency Medicine Quality Improvement Project, and specifically the 3 standards, we used as a basis to design and implement our tool and an associated patient information leaflet. And the standards, I think, are very good. They're very straightforward. They sort of cover everything that we want to cover. So there should be written evidence that the patient who were fitted with a new leg cast or boot have their risk of VTE and bleeding assessed during their visit to the emergency department, or in our case, the trauma clinic. Standard 2, there should be written evidence that the patient information leaflet outlining the risks and the need to seek medical attention if the patient develops any symptoms is given to all patients with a temporary lower limb immobilization. And again, this includes the treatment as well. So that information leaflet contains information on low molecular weight heparin treatment and a DOAC treatment. So we've not got 2 separate leaflets for each group of patients. We've got 1 leaflet that covers everybody. And the 3rd standard was, if pharmacological thromboprophylaxis is documented as being indicated, there should be written evidence of the treatment having been initiated either in the AED or in the trauma clinic. And we found with all 3 of these standards, we've implemented them into our tool. that, as with all good practice, documentation in the patient's notes, the cash card on our risk assessment tool. So we've got it documented, the process that the patient's been through and what's been decided, what's been prescribed, so that we're protecting the patient and ensuring that they know exactly what's going on, and also protecting ourselves, that if there are any issues in the future, that we've demonstrated that we've complied with the standards that we were required to comply with. So we used a Plan, Do, Study, Act, or the PDSA quality improvement approach to evaluate our tool as fit for purpose. We used mixed clinicians in the trauma clinic and the A&E department, and they all engaged in the process. We did 9 cycles of changes before the tool was considered fit for purpose. And we also spoke to 2 patients in trauma clinic, and these 2 patients, we wanted to find out what their thoughts were about either being offered an injection of low molecular weight heparin, or the possibility of a tablet that they could take every day, either or for the next 6 weeks potentially. And we found that some patients don't like needles at all. You know, they can't bear the thought of having a needle. Some patients were happy to start with a needle, but people report back that after 2 or 3 weeks, they can't bear the thought of sticking the needle in themselves again. Plus there's all the bruising and the sore areas on the abdomen that can become quite a problem. There was also the time it takes to teach patients in the clinic to inject themselves, and that's using the nurse resource in the clinic or in the A&E department. There was also the possible need of using a district nurse to call every day, potentially for 6 weeks. And again, that being a huge resource, you know, and taking the district nurses out of their other duties to come in and inject patients. And also, the other thing that we found was that low molecular weight heparin is not available in Wales from the GP unless you reach certain criteria, such as you're pregnant or you have active cancer or you're having prophylaxis for cancer. And that means that we either give the patient a 6-week supply in a carrier bag when they go home from clinic, or we bring them back to clinic or back to the pharmacy to keep giving them the repeat prescriptions for the 6 weeks. And that can be quite inconvenient for patients who have to keep going back to the hospital, particularly if they live quite a distance away. So we consulted with our 2 patients just to get some idea of what they felt about it, just so that, you know, we had their input, and they were quite positive about changing over to the DOAC from the low molecular weight heparin. Now, the PDSA cycle changes that we made 9 altogether. Well, we made more than 9. We changed the tool 9 times until eventually we had version 10. We made more than 10 changes, but these were just a few of the changes we made. So we found that the creatinine clearance with the DOACs that is recommended, we use the Croft Gold, which I think is more commonly used now everywhere. And we use the MedCalc calculation tool online to do our Croft Gold calculations, whereas low molecular weight heparin used the EGFR. So we aligned the dosage boxes on the tool for the use of Croft Gold with reference to renal impairment, and that was for both the DOACs and the low molecular weight heparin, so that there was no confusion. We used Croft Gold for both, and that was that. The orthopedic consultants felt that not all patients fit the risk assessment tool, but clinically TP, thromboprophylaxis might be or was required. And so we took the clinical decision to put a TP required box onto the tool. Now, that doesn't mean that they can just tick that box and sign the bottom and that's them done. The tool has to be completed in its entirety. And I'll show you the tool in a bit because there's quite a lot on there. So we didn't want them just thinking they could tick that box and then it was like a get out of jail free card. And then there was a need for patients to acknowledge the need to treat had been discussed with the patient, and they gave their consent. And also this includes the consent of the use of an unlicensed medication. Now, low molecular weight heparin isn't licensed to give to patients with lower limb immobility, but it has been used for some time. And really, for any off-license drug, we should be filling out the GMC documentation and discussing with the patient, and they agree to use an off-license medication. But I would question that this perhaps doesn't happen as often as it should. So what we did was, in the tool, to make it as comprehensive as possible, and so we didn't have lots of different forms and the tool and lots of paperwork, which meant clinicians had more work to do, we tried to incorporate it all in a double A4 size sheet. So we added onto the tool a section on the use of the unlicensed drug adapted from prescribed and unlicensed medicine from the GMC 2021, and also a patient's signature section was added. So the patient could be counselled. They could also be informed that this was an unlicensed drug, and if they were happy then to proceed, they would sign the form, and that goes into the patient's notes as a record. So we did a multi-professional review, sorry, I'm checking my time here, by the Lower Limb Immobility Project team. That was myself, the senior pharmacist with an interest in anticoagulation, the TNO consultant and SPR, and the nurses in the trauma clinic, an A&E consultant, and an A&E and advanced nurse practitioner. So once the tool had been agreed by all of the members of the project team, I then sent it out to the Princess of Wales Hospital Thrombosis and Anticoagulation Committee and invited them to make comments. Well, we only received one comment, and that was regarding the use of off-licensed medication, and we addressed that. So all the documents which incorporated medicines such as the dose, the route, the technical information, they had all been clinically and accurately checked by the senior pharmacist. And then the tool was submitted for ratification from the Medicines Management Committee. And unfortunately, due to these difficult times with COVID, we're still waiting for it to be ratified through that committee. But rather than sitting and waiting and not doing anything till it hopefully gets ratified, we've carried on then and looking at implementing and how we're going to move forward with the next phase. So the tool will be introduced to clinicians and associated staff in trauma clinic and the A&E department once it's hopefully been ratified. All relevant staff will be trained in the use of the tool and how to complete the risk assessment, but also how to identify if the tool has been incorrectly completed. We all look in notes or see patients' notes and that where only part of them has been filled in. And I find that quite irritating at times when there's no dates on forms, there's a date but no time, there's a date but no year, patients' details aren't filled in properly. Even staff who put their first name and don't put the rest of their name, so it would be quite difficult to maybe find them in the future. Also, blood results, whether the patient has had the patient information leaflet. So we need everybody to have an eye on this form so that if the clinician fills it in, passes it over to the nurses for them then to sort out the patient getting their prescription, the nurse can look over it and say, oh, hang on, you've not filled this bit in, and make sure that it is filled in completely. So the clinicians, junior clinicians, and that's pharmacists, nurses, doctors, are empowered. We will empower them to raise concerns to senior clinicians when appropriate. And a record of all patients who have been risk assessed and offered treatment will be retained as a means of identifying problems and auditing the change to ensure that the 3 standards are adhered to in every patient. And also that if there are any adverse events, we can pick those up as well. And this will give us a good record of how well the tool is performing and you know, if we need to make any future changes. The tool will be communicated to staff in the pharmacy department for information regarding the introduction of a new clinical prescribing tool using an off-licensed medication. And again, if it comes back from the Medicines Management Committee and we have to make any changes, then we can do that, hopefully get it ratified, and then roll it out. With regards to governance and reducing risk, the tool for patients with lower limb immobilization is introduced in line with the All Wales Thromboprophylaxis policy, recommending the thromboprophylaxis risk assessment for patients with lower limb immobilization. The All Wales policy was designed so that all of the 7 health boards in Wales use the same thromboprophylaxis risk assessment policy, and that's based on NICE CG 89. And we implemented that in February 2020, which is very good because it means that any doctors moving from one hospital to another within Wales are familiar with the policy because it's the same across the whole of Wales. And also it means that when we introduce anything that's aligned to that policy, it's reflective across the whole of Wales and all the health boards. So this is the tool. I'll show you the tool in a moment because it is quite small on there, but I've got a Word version of it I can show you. So it's double-sided. It fits quite nicely onto the A4 sheet, which is good. And this is the patient information leaflet, which I was very pleased that my colleague Marilyn Rees, who's the thromboprophylaxis nurse in UHW in Cardiff, they kindly shared with me. And we then amended it to suit our needs in Wales, in Bridgend. There's also a tool that I found in Leeds. They have a similar tool. And if there's anybody out there who's interested in these tools, I'm happy to share them because I don't see there's a need to reinvent the wheel. And if I've got something or you've got something and we can amend it to suit our needs and it fits the what we want it for, then well, I'm very happy to share. So if anybody wants a copy of this, then I'm happy to send it to them. And I'm sure Marilyn won't mind if I do that. I'm sure, I don't think, she won't mind, I know she won't. So acknowledgements, as I've said before, Rhian Donald, Senior Pharmacist, who unfortunately wasn't able to be with me today. Then Mr. Glyn Torn, Mr. Chandra Treya, Mr. Mohammed, Rose Davis in emergency care, Ms. Jane Griffiths, and Sister Marilyn Rees. So diolch yn fawr, and thank you very much. Now, I shall show you the tools in a better light. Won't be a moment. So this is the risk assessment for patients with lower limb immobilization. And as you can see, we'd asked that clinicians consider thromboprophylaxis if both of the following criteria were met. So we've got 1 and 2 there. Then we've got the NHS VTE risk factors, which we use. And again, that's in line with NICE CG 89. And then number 3, we have the box where if the patient doesn't meet the above criteria, but some prophylaxis clinically appropriate, tick here. And as you can see, we have the contradictions on there for anticoagulation, but also additional contraindications specific to rivaroxaban. Clinician would sign at the bottom, and regarding any specific concerns to contact haematology. Then on the other side, asking if some prophylaxis is indicated. Now, baseline bloods, that was one of the changes we made during our PDSA cycles. There were patients who were young, fit men and women who had no other problems other than a fracture and an immobile limb. So we asked clinicians to consider if the patients had had previous bloods done and if all patients needed to have all of their bloods done. And we basically, depending on the patient's clinical condition and also the fact that when they possibly originally came in with their fracture or their injury. Bloods may have been done in the A&E department. There's a good chance that we would have blood on every patient anyway. For those patients who were more elderly and may have had some renal impairment or may have had other comorbidities, then the need for bloods was more essential. We asked if drug interactions had been considered. And then the section on DOACs not licensed for use in patients under 18. That was quite interesting because the Royal College of Emergency Medicine looked at patients of over 17. The NICE guidance looks at patients over 16, but the drugs aren't actually licensed for people under 18. So we have 3 different ages there, but we went with the fact that they're not licensed for anybody under 18 seemed to be a good cutoff, unless there was a reason why the clinician felt that the patient needed to be, given the DOAC. So that section there, which we had adapted from the GMC, has a decision to treat and discuss with the patient. It's just a tick box. Does the patient consent to use an off-licensed medicine? It's another tick box. Has it been prescribed? If no, why? If it has, yes. For which drug and for how long? And then the patient signs to the consent of using an unlicensed medicine, and then the prescriber signs that as well. And that is really important because so many people come back and say, well, nobody told me that. I didn't know that. And so, well, we can demonstrate that we have advised the patient and we have given them the information, and reducing the risk of developing a blood clot in a patient with lower limb immobilization, another tick box for the leaflet. We're adhering to those standards that we need to adhere to. And it protects the patients because it's like a checklist that everything has been done that needs to be done. And then the last part is the prescription. So the first line is forrivaroxaban tablets, 10 milligrams once a day for at least 6 weeks. And second line is enoxaparin by subcut injection, again for at least 6 weeks. And then there's monitoring for HIT. So the tool itself is quite comprehensive, and there's a lot of information on it, but we felt that it was better to try and put it in a way that was set out well, it's readable, but it covers everything we needed to cover. And I'll just show you quickly the patient information leaflet. So this is the patient information leaflet. Now it folds up in a 3-way. So you have to imagine that the front page is the side on the right, the PE bit and shortness of breath bit in the middle, and then the other bits on the back. And there is a reverse side to this as well. So as you can see, it's talking about how the clot forms, the difference between a DVT and a PE, and the symptoms. What if you forget to take your medication or you don't take your anticoagulation? And I'll just show you the B side. Where is it? Oh, one second. I've lost the B side. Oh, there it is. No, wrong one. Sorry. Apologise. As you can tell, I am not very good with this. Oh, I seem to have lost it. Well, the B side has got the medication on it. It's got the low molecular weight heparin, and it's got the DOAC. So depending on which medication the patient has been given, would depend on what guidance is on there, and whether they're on one or the other, the information that's relevant to them is on there. And so patients, there's a telephone number on there, so if patients have got any queries, it advises them where to go to. There's a number they can call if they've got any problems. And hopefully we're giving patients as much information as we can to alleviate their concerns and anxieties, and also keeping them safe from developing a clot while they've got an immobile limb. So that's the end of my presentation. Thank you very much. If there's any questions, I'm happy to take them. Thank you.
Thank you, Andrea. That was really good. And yes, a reminder, just please type questions or comments into either the chat or the Q&A tools, and we can take those. I was interested, obviously, this work was quite intensive and included a multidiscipline team. Was it initially difficult to pull that team together and have everybody willing to be participating in it?
No, it wasn't actually. We're quite lucky here. I think the orthopaedic team were very keen to get something in place, and they're a very good team in the Princess of Wales Hospital. They're very engaging, and I think, well, I've nagged them for 25 years around thromboprophylaxis and hospital-acquired thrombosis, and I've worked quite closely with them. And also the clinicians in A&E, again, were very keen to get something put in place. One of the biggest stumbling blocks to put in a tool in years ago was getting agreement who was going to check the platelets at 6 days with the low molecular weight heparin. And there's a lot of places now that don't check the platelets. I know I spoke to people in Dublin when we went there a few years ago with National Thrombosis Week. And one of the issues is if the patient started on a low molecular weight heparin in the trauma and orthopedic clinic, where do they come back to have the platelets checked? And once they've had them checked, who chases up the result and does something about it? A&E wouldn't, they said it wasn't part of their role to do that. T&O clinic, they didn't feel it was part of their role to do that. And so it became a big sort of stumbling block, and as a result, it didn't get done. So now with the DOACs, I mean, certainly with the DOACs where we've put patients, transferred them from warfarin onto a DOAC, it gives patients such a lot more freedom. And it's, I think psychologically, sticking a needle in your stomach every day, it's not pleasant. It can sting. It leaves those little marble-sized bruises on your stomach if you're unlucky enough to get them. It does get more difficult the longer you do it. But to take one tablet a day, and even for our older population who need them, if they have Dosset box that's prepared in the chemist, we can liaise with the chemist and the GP, and they can be put into the tablet box, and we know that they're going to be safely taking their medication and hopefully preventing them from having any embolic events while they've got their leg in plaster or it's immobile.
Several questions are coming about. What percentage of patients need prophylaxis, have you found?
Well, I would say all patients need risk assessing for thromboprophylaxis. The figure that actually get it, I couldn't tell you that for this group of patients because I don't know. But all patients should be risk assessed 100%. And even patients where it's clearly not going to be required, like patients who have come in with an open fracture, or patients who have got some contraindicating condition which prevents them having thromboprophylaxis, patient who's a query stroke or has got a gastric bleed or whatever. It's as important to risk assess those patients as it is to risk assess those who you think are going to need thromboprophylaxis, because we need to document that they don't need it, so they don't get it. One of the things you find is that nothing's written on the page. It is much better now, I hasten to add, but if you don't write it down that it's not required because the patient's going for a CT scan of the head because they're a query stroke or they've had a head injury, it leaves room for potential error. So if you're not going to give it, document why you're not going to give it, and document that either on your medication chart, in the patient's notes, make it clear that the patient does not require thromboprophylaxis. And then, in line with the NICE guidance, where you assess the patient 24 hours or as their condition changes.
It's such sensible advice, thank you. Also, are you planning to look at weight restrictions of 120 kilograms for forrivaroxaban?
Well, I was talking to, I think, Dr. Ali Khan did, he did a piece of work recently, and if Marilyn's around, are you there, Marilyn? Marilyn might be able to add to this. I think they'd increased the weight to 140 kilograms off the top of my head. But with that particular dose of the 10 milligrams once daily, we took that dose because that was the dose for patients who had either had orthopedic surgery, extended prophylaxis in knees. And we, obviously, if we had a patient who was extremely obese, then we would consider that. But I think that the guidance has gone up to 140, but I would have to check that with Rhian. I shall ask her about that just because somebody's asked me.
Thank you. How long from sort of, you mentioned before you tried with warfarin and obviously it wasn't successful for some practical reasons. How long did it take you to actually bring this to implementation from restarting the project?
Well, once we restarted, it's been quite quick. We started it in 2019, and then of course everything was put on hold. I came back to the hospital in November last year, and I think Rhian and I first met in January this year. And because everybody was very keen to get this moving, one of the biggest barriers, and I'm sure this is the same for everybody wherever you are in the world, because of the pandemic, we're all doing different jobs. I'm actually doing mortality reviews at the moment. This is a sideline. And with everybody doing different jobs and things being added to their roles or them giving new roles because of so many people off with COVID, it has been very difficult to try and get everybody together. So I guess I took a lead with it and tried to meet up with people either separately or send everything out to people together so that at least although I met them individually, I could bring them together then by emails. And particularly, I met with A&E, Rhian and I met as often as we could. I go down to the TNO clinic quite regularly and speak to the staff down there. So I kind of had an idea of what was going on all around, and I could go and collect all my bits and pieces as and when I was able. And then once we'd got everything together, sent it out to the TNA committee, which is our Thrombosis committee, which I deal with online anyway. So everybody had sight of it. And once it had come back from there, it was just a case of sending it to the Medicines Management Committee. They weren't meeting regularly because of COVID, but I asked if it could be put through as an urgent case. They were doing urgent cases, so we're waiting for it to be reported on, hopefully very, very soon. But not wanting to sit around and wait another year before we did anything. We've done everything now, so as soon as we get the okay from them, whenever that is, we can implement it.
So ultimately, with the right team and a multidiscipline team, obviously, and without COVID, it can be achieved in a relatively short time, but it does need that drive. And you mentioned in your presentation about training. Do you have any specifics training that you're going to roll out for staff on this?
Well, they do training in A&E. They have a training room and they do training there, so we'll tag on to that. Pharmacy have a training room and they do weekly training, so we'll tag on to that. The orthopedics have a monthly audit meeting. I've already met with them and showed them the tool, and I met with a lot of the orthopedic consultants and SPR separately. The team in the clinic have been brilliant. And Jane down there has been involved since the beginning. She got us our 2 patients who we sort of discussed things with. So yeah, we've engaged with everybody and they're aware that this is coming and they want it. I think that's the most important thing, is that they want it and they can see the benefit. So hopefully once it's out there, and I find that if everybody's got ownership, we don't just say, okay, this is for the consultants, this is for the SPRs, this is for the nurses. If everybody's got ownership of it, if something isn't done, then the other members of the team feel more empowered to say, oh, hang on a minute, you've not done that bit. And that's how I've worked with everything I've done, much to some people's dismay. But if everybody is responsible and everybody's checking what everybody else is doing, we stand more of a chance of getting it done properly.
Yeah, I think you're right. And finding those opportunities rather than having to make new things, for instance, for training, fits in smoothly with everybody. I guess, I mean, the last question, probably because of the time, is you shared the patient information. Are you also getting feedback from patients and seeing if even them having that information at point of thromboprophylaxis might mean faster presentation should they develop any signs or symptoms? It could be a clot.
Well, the two patients that we showed it to both had no problems at all, but they were reassured that they had information to, to give them specific advice on what to look for. There used to be information given out to patients who had had knee replacements, and the knee replacement information said, don't worry if your leg is red or swollen or becomes painful, because that's normal after a knee replacement, but it's also the signs and symptoms of a clot. So we tinkered with that documentation because patients weren't reporting because they thought it was normal. So this is more specific, and these are one of the things, or some of the things that we'll look at when we're looking after the implementation, what patients thought of it, if there's anything that needs to be changed. If anybody does come in who's had a clot, we'll be able to pick them up because it'll flag it up on the system, and we'll be able to identify them. They'll also come back into clinic, and hopefully Jane will pick them up. So again, working with everybody knows what you're involved in, and if something happens, they'll report it back to you. And I know that's not the same for everywhere, because some hospitals are so huge and impersonal that a lot of staff don't know each other. We're not a small hospital by any means, but we're not massive either. And I think one of the things that has been more use than anything else, and I know my colleague Christine up in North Wales would agree with this, is having a dedicated thromboprophylaxis nurse, because we're kind of the glue that holds everything else together. Although we're doing other things, you've kind of got a handle on everything, and everybody knows that's who you are. And if they need some advice on thromboprophylaxis, or if they need to ask you about something, or they want something implemented, they know where to find you. And also, you can get a good rapport with your teams and with other members of staff. And I think it makes it easier then when you engage with people to move things along. It still took 25 years, but we got there, there's always things to be done.
I think you're right, though. I think you are the glue, but also you have ownership. And by the communication, which is really what you're talking about, with all the other specialities, bring in both their knowledge, so it brings in clinical data, it brings in their expertise, and it's also for the patient benefit. So you've got all three parts that are essential to make this both successful, but everybody buy in, which is a fantastic take-home message. So thank you, Andrea.
That's okay. You're very welcome, and thank you very much for everyone's attention.
That's a pleasure. Yep, thank you everybody for joining. This will be available very shortly. And one last message that's come through saying, I totally agree with you, Andrea, and it's great to have colleagues like you to have to work and to share knowledge and experience. And I know you're very happy to take emails or from anybody who wants to see anything. So
yeah, definitely. And thank you very much for everybody's interest. It's a fight that we've got to keep fighting. So thank you.